Hey, many thanks for inviting me to talk today on what's already been a very informative and inspiring session. If I could have my first slide, please. So my objective today is to highlight to you the many ways that the pharmacy profession can make a difference in the asthma care of children and young people and contribute to them living their best lives. Next slide, please. So we're all very familiar with these unmet needs and challenges in managing asthma in children and young people, so I won't dwell too long outlining this. But in the context of the size of the challenge, and we've just heard this reiterated by Sarah Sleet, approximately 1 in 11 children in the UK have asthma, and 1 million children in the UK are receiving treatment for asthma. And we have poor outcomes, especially among children and young people from lower socioeconomic backgrounds. Children and young people with uncontrolled asthma are also at high risk of developing adult respiratory disease, such as COPD. They have mental health difficulties, such as anxiety, and they also tend to have poor educational outcomes. We also know that most hospital admissions and asthma-related deaths are preventable, including the September surge in admissions that we see annually. So the next two challenges form part of the NHS Core 20+5 targets to reduce health inequalities. We have too much reliance on short-acting beta agonists as rescue, which increase airway reactivity and risk of hospitalisation because they have no anti-inflammatory component. And we also know that inhaled corticosteroids are being underused. So we need to do everything that we can to optimise adherence here, improve understanding of the inflammatory nature of asthma, and address the negative perceptions of inhaled steroids and fears of side effects. And we also have a challenge of changing perceptions of what asthma control looks like, and this is across the board. So this is parents, young people with asthma, their peers, teachers, just society as a whole, because asthma is not controlled if a child is sitting out of PE or can only play a football match until half time. And I hear this from my own children. Oh, so-and-so doesn't go to athletics because he has asthma. So we've got a lot of work to do here. So improving adherence or concordance in all people with asthma is a significant challenge. Adherence to asthma medications is estimated to be about 50% in the general population, although some studies have found this to be higher in children at about 69%, although this is in studies where there is an awareness that adherence is being monitored, so they're not necessarily representative of the real world. But it's also still suboptimal, so we should really be aiming for adherence of greater than 75%, as well established to correlate with decreased frequency of exacerbations, and this also forms part of the eligibility assessments when considering escalating treatment in severe asthmatics to commissioned biologic therapies. Adherence has also been found to decrease with increasing age, with rates as low as 38% being reported in adolescents, so this poses a real challenge for us. Next slide, please. So how can the pharmacy profession help? So we're a really diverse profession working across many sectors. So I thought I'd first introduce you to who we are and where we are as a profession to better understand what our contribution to asthma care can be. So pharmacies and primary care, we're in community pharmacies, practice-based pharmacies, practice-based in GP surgeries, in primary care network positions, and also in hospital pharmacies and in industry. Next slide, please. So in community, the pharmacy team is made up of pharmacists, pharmacy technicians, accredited checking technicians, dispensing assistants, and medicines counter assistants. And they're a uniquely accessible healthcare resource. So 89% of the population in England has a community pharmacy within a 20-minute walk, and this rises to 99% in areas of higher deprivation. They're a very approachable team, accessible without appointment, and can help with tackling the basics of asthma care, and are increasingly being utilised to provide other advanced frontline health services. And I'll come on to talk about more of those later. Next slide, please. So we, as I said, we have pharmacists working in primary care and practice-based pharmacists, and also primary care network pharmacists who all contribute to better health outcomes. These are clinical pharmacists. They're either working in a large team across multiple network sites or within a single practice where they're directly managing individuals' medications. So PCN pharmacists will be involved in policy developments and commissioning pharmacy schemes in their area. Practice-based pharmacists will undertake structured medication and annual reviews supporting GPs, and in some cases they might even do the post-admission 48-hour reviews if they've been trained correctly. And both can access prescribing dashboards to identify high-risk prescribing patterns across the network or in individual surgeries, excuse me, allowing us to focus on a wider population health and targeting interventions to those who are most at risk. Next slide, please. In secondary care, we have hospital pharmacy teams made up of pharmacists, technicians and dispensing assistants, and they're all contributing directly to patient care. Both pharmacists and more experienced technicians in hospital are involved in medicines optimisation during hospital admissions, which could be for asthma exacerbations, or they could be for other reasons, including surgery, where it is essential to ensure that correct asthma treatment is being maintained. They work with families, educate them, and can check inhaler techniques and help with the understanding of asthma management and discharge plans. And it's a really good time to assess and optimise the basics. And we also have consultant and advanced practice pharmacists who are also in clinics managing patients, including those with difficult asthma, and are usually independent prescribers. And they're essential contributors to the multidisciplinary team. We optimise asthma care and including advice on the use of medicines or devices outside of their licence, which sometimes are more suited to an individual and can promote better adherence. And we'll also work to work up patients for eligibility for asthma biologics and eligibility for clinical trials. So I've touched on an awful lot of things here, but I will look at some of these a little bit more closely. If I could have my next slide, please. So I've mentioned medicines optimisation on this last slide. This really is the bread and butter of pharmacy care in all sectors. So it's an umbrella term for having a patient-centred, evidence-based approach to ensuring that the correct medication is safely prescribed for the individual while engaging people with their treatment and understanding their experiences and priorities. So this could be finding the right routine for a patient while optimising drug delivery with different inhaler devices, but taking into account their individual preference, so shared decision making. And in our particular cohort, we must always remember to engage with the child directly, not just speaking to their grown-up, but hear their voice and gain a measure of their level of understanding and health literacy, and then adapting this information as they get older to improve the chances of adherence in adolescence. And pharmacists can help to address this particular challenge. So with increasing autonomy, busy and changing routines, sleep patterns, young people do really need some help to find out what works for them and empower them to tailor their care to their life. And engagement of all pharmacists in all sectors with this cohort is essential so that they can tackle this wherever the opportunity presents itself. Pharmacists in all sectors can also help to identify non-adherence, so we can review prescription collection rates, we can provide medicines possession ratios, and we should be aiming for more than 0.75, which is 75% possession of their medication. And we can also look at issue ratios of relievers to preventers and target those who seem to have an over-reliance on reliever therapies with excessive SABA use. NHS digital systems play a crucial role in facilitating this to pharmacists so that we can access GP records, but this unfortunately is still not consistent in all regions. And just going back to non-adherence, so this really must be considered prior to escalating any asthma care or at any point of acute treatment, such as prescribing short courses of oral corticosteroids. So it is essential to always ask, is currently prescribed therapy actually being taken? So I frequently see patients who have received multiple courses of oral corticosteroids, they've been escalated to high-dose inhaled steroids, and they've only collected 2 of their previous preventer inhalers in a year. So an adherence intervention when asthma control has evidently slipped and there's been an exacerbation, it's a really impactful time to discuss this. So this can be done by practice-based pharmacists at point of acute consultation and prescribing, or at a scheduled asthma review. It can be done by community teams at the point of dispensing, or by hospital pharmacists during admissions, for exacerbations, or in follow-up in outpatient clinic. So again, this requires consistent access to GP prescribing systems and for these techniques to be embedded in our routine practice. Next slide, please. So another part of pharmacy's role in medicines optimisation includes teaching how to use these devices correctly. And we should be doing this at every opportunity in line with making every contact count. So this means educating on optimal inhaler techniques for the different inhaler types, finding the most suitable device for an individual, correct use of the spacer devices. I think the boy in the picture needs a little help with this. And correct use of nasal sprays, because many don't know how to use these correctly or have never been shown how. And it all needs regular reinforcement and recognition that needs and preferences will change as children grow up. Older children should also be encouraged to become more autonomous with their treatments and be given the skills and information to self-manage. And we also need to be mindful of sustainability targets and moving towards NHS net zero when choosing our inhaler devices. But I do think it's important to note here that although there is a significant drive to use the environmentally greener dry powder inhalers over the pressurised MDIs, not all these devices are suitable for younger children or those with neurodiversities. So finding the correct device for the patient is our greatest priority, as uncontrolled asthma carries a higher environmental, healthcare and individual burden. And these will be really important factors to consider, and we've touched on this a little bit earlier, when implementing the new BTS NICE guidance, in which the current draft recommends off-label maintenance and reliever therapy regimes for under 12s. So these aren't licensed, so the devices themselves are, but using them as MART is not licensed. And we'll need to be really careful to consider which devices are most appropriate in this patient group. And just going back more broadly, pharmacy teams can also contribute to the broader education and counselling of children and young people, including minimising exposure to triggers such as pollen and pollution and pets, a lot of P's, and also advise on general health, nutrition, healthy lifestyle choices and managing stress, all of which will contribute to better outcomes. And when we heard from Ian Sinnott earlier, this is 33% of the solution in asthma care, making sure that we've got healthy lifestyle choices. Next slide, please. So community pharmacies also play an essential role in managing minor ailments which can exacerbate asthma, providing the opportunity to ensure asthma medications are being taken with concurrent illness, and also providing advice on the management of colds, hay fever, atopic dermatitis, with the use of over-the-counter therapies and promoting appropriate self-care. Also very recently launched in England is the Pharmacy First scheme, which has enabled pharmacists to better treat and prescribe for a range of minor ailments for children and young people. So this includes sore throats, otitis media, impetigo and infected insect bites. Admittedly, not all of these impact directly on asthma care, but they do reduce pressures on stretched GP systems. And a similar system is already in place in Scotland, Wales and Northern Ireland. And there are further indications that can be prescribed for adults or accessed for adults in pharmacies. So people can be seen in a pharmacy without an appointment, and after answering a number of screening questions, they can then be prescribed treatments such as antibiotics where it is appropriate. Pharmacists can also help with illness prevention by increasing understanding and promoting the uptake of child vaccination schedules and boosters that are available for patients at risk, such as the pneumococcal, and also participate in seasonal vaccination programmes, including COVID and influenza. And some ICBs commission pharmacies to facilitate the influenza programme and mop up those who have missed vaccination in school. Next slide, please. So another vital contribution in community pharmacy comes under the Pharmacy Quality Scheme, which is a payment scheme which forms part of the community pharmacy contract. And this includes a respiratory section, which has criteria for inhaler technique checks, inhaler waste management, ensuring the use of a spacer in all 5 to 15-year-olds who are prescribed an MDI, and that all patients over the age of 5 who are dispensed and have an inhaler also have a personalised asthma action plan. And all patients dispensed more than 3 SABA inhalers in 6 months without an ICS are then also referred back for an asthma review. So the basis of these criteria was to address recommendations from the NRAD report and also the NHS long-term plan in terms of moving towards NHS net zero. Next slide, please. So how do we ensure our pharmacy workforce is equipped to support patients properly? So achieving these criteria, the community pharmacy contract has direct links to resources available from the Centre for Pharmacy Postgraduate Education, with e-learning packages on optimising inhaler techniques, and there's an assessment as well for healthcare professionals there. So any GPHC registered pharmacists or pharmacy technicians, they can access these simply by registering for a login. Next slide, please. So also provided under this pharmacy quality scheme is the new medicine service. And this supports people prescribed a new medicine or where there has been a change of inhaler device, aiming to ensure correct use and improve adherence and self-management of their condition. So there's 3 stages. There's patient engagement, so the service is referred into by the prescriber, there's initial advice given about the medicine, and then patients can opt in for follow-up intervention at an agreed time, which is either done face-to-face or by telephone, or can be done by video consultation. And then further to this, there's a follow-up appointment to further assess adherence, address any concerns, manage and advise on side effects, and determine if any further support is needed or referral back to the prescriber if indicated. So the services for adults, but also for children and young people, although this does seem to be less widely utilised. It may be because the criteria was only expanded to include under 16s in 2021, and this was following a report by the Healthcare Safety Investigation Branch into a child who suffered a near-fatal asthma attack aged 5. Here there had been adherence concerns identified but not resolved, and the community pharmacist was found to have had minimal access to any information and no mechanism of feedback of non-collection of prescriptions to the GP. So this service is very much a step in the right direction to collaborative healthcare. There are still, however, improvements needed to the digital systems, access to shared care records and mechanisms for referral. So they still vary. Read-write access to systems is not widely available, and communications is sometimes still just via NHS mail or by phoning the GP in the same system as patients. So both of these are problems with timeliness of the interventions. Next slide, please. And very similar to this, the NMS, we've got the discharge medicine service, and this has been put in place to allow hospital pharmacy teams to identify patients who may benefit from referral directly to their community pharmacy on discharge. So prescribers and pharmacists refer via secure electronic systems to ensure seamless transition and aiming to reduce avoidable medicine-related harms associated with transfers of care, and also reduce hospital readmission rates. So again, this is being utilised by many adult services, but is a lot slower to get off the ground for children and young people. And we currently cannot refer into this from outpatient clinics, which I think would be useful. But both of these services will be really useful services to utilise when implementing changes to asthma therapy proposed by the new BTS and NICE joint guidelines, because there might be quite a few patients who are then being treated with new devices. Next slide, please. So no pharmacy presentation these days is complete without mentioning sustainability. Another contribution of pharmacy to asthma care is inhaler recycling or disposal. So it's still not commonly known that inhalers should not be disposed of in household waste. Patients should be encouraged to return them to pharmacies for incineration with medical waste to avoid them going into landfill where they can emit greenhouse gases. Recycling schemes, however, are sporadic. Previously, there were pharma-funded schemes. There was the GSK Complete the Cycle, Teva had TerraCycle, and local to me in Leicestershire, we had the Kaizi Take Care scheme. And that was a 2-year pilot where we recycled 52,000 inhalers and saved 305 tonnes of CO2. And in 1 year, the Take Care scheme, together with the GSK-funded scheme, recycled 3 million inhalers, saving CO2 emissions equivalent to removing 16,000 cars from the road, which is obviously really positive, but there is, however, no funded national recycling scheme currently available. So there are schemes that trusts and pharmacies can sign up to, but they need to be paid for, and the cost effectiveness of these is yet to be determined, and feasibility is currently being looked at in terms of medical incineration versus recycling. Next slide, please. Pharmacies are also ideally placed to provide vaping and smoking cessation advice. Community pharmacies currently support patients discharged from hospital with free access to nicotine replacement therapies if they've been started in hospital, but it's only open to those over the age of 18. It would be really useful if this is something we could refer into for parents and carers of children of young people admitted with asthma who are exposed to smoke in the home or who regularly smoke themselves. Unfortunately, this is not the case, though. It's different to the swap to stop scheme, which encourages the use of vapes and provides a free starter kit. Some pharmacies are participating in this scheme, but increasingly the evidence for effects of passive vaping means it's not really appropriate in a home where there are people with asthma. Next slide, please. So we've had a really interesting presentation from Mira earlier. So we increasingly know that vaping has its own toxicities. The tobacco and vapes bill is a step in the right direction to regulating these products. However, most resources focus on prevention and educating young people about the risks of vaping. It doesn't address the challenges of those currently vaping and already with a nicotine addiction. Currently, vaping cessation services are not widely available for under 18s, echoing what Mira was saying earlier. I did a quick search on this when I was writing this presentation, which yielded one programme in Peterborough and Cambridgeshire schools, which targeted cessation in Key Stage 3 and Key Stage 4 pupils. And that's literally all I could find. So I'm sure there's more the pharmacy profession could do to contribute in this area, though currently there is no training or information for pharmacists, but it is possibly a role that we could take on in the future. Next slide, please. So just wanted to talk to you a little bit about transition care. Pharmacists should and do get involved in the transition process for children. There was a patient who spoke on last year's Ask About Asthma conference discussing issues around transition, who said that no one had given them advice on prescription reordering. So this is an opportunity for pharmacists to help the process. They can advise young people on mechanisms for reordering, what to do if they lose their inhaler or need emergency access to repeat medicines at weekends, bank holidays, when they're on holiday or when they're moving to further education. They can also be given advice on understanding prescribing charges, applying for prepayment certificates, and at the point of prescribing, advising on rationalising treatments to reduce prescription charges. Currently it's £9.90 per item. So that's or £114.50 for an annual prescription prepayment certificate. Currently prescriptions are free in Scotland and Wales, but they're only free in England for over 16s in full-time education. There are calls from the Royal Pharmaceutical Society and the Prescription Charges Coalition for the government to scrap prescription charges. I don't know where that is in the process, but hopefully it is something that might be on the agenda soon. Next slide, please. So I'm a little over time, so I'm just going to blaze through this one quickly. Just a quick mention about how pharmacists can play a role in managing asthma in schools and support the Asthma Friendly Schools Partnership. So pharmacies can supply inhalers. The schools can purchase salbutamol inhalers and spacers for emergency use without a prescription. Asthma UK study found that 86% of children have at some time been without their inhaler in school. So this just helps to ensure that children have access to inhalers, even if they forget, lose or run out of their own. And I'll move on here if I could have my next slide, please. So where do we go from here? To improve the care for children and young people with asthma. So as mentioned in the last few slides, there are many opportunities for the pharmacy profession to further contribute to asthma care, and some of these services could be more widely implemented. We're all very familiar with the National Bundle of Care, and hopefully have shown you how the pharmacy team in all sectors is essential to achieving some of the deliverable targets, including prescribing rates of SABAs, ratios of preventers to relievers, and reducing oral corticosteroid use and ED attendances and admissions. But for some of these services, we do need to upskill the pharmacy workforce to better understand asthma care, specifically for children and young people, to improve outcomes for them. Next slide, please. Which leads me very nicely onto the National Capabilities Framework. And I think this is training that could really benefit pharmacy teams across all sectors. Community pharmacy teams and at tiers 1 and 2, probably most appropriate, and also for specialist technicians working in secondary care and all secondary care pharmacists who have an involvement at any level with children and young people with asthma, including just on call or at weekends. Tier 3 would be most appropriate for practice-based and primary care network pharmacists and advanced specialist pharmacists who are working in paediatrics. And these are all free and accessed via the e-learning for healthcare website. Ideally, the advanced pharmacist practitioners and consultant pharmacists should be being funded to complete Tier 4 training. I've done this and it is a really useful programme. But I do think we need better promotion of this framework in the pharmacy profession, as it's not well known about as a resource to access. And this ties in with comments from Dr. Jen Townsend this morning. So ahead of this conference, I have had some positive discussions with CPPE and the RPS to see if we can seek their endorsement or promotion of the capability framework to raise its awareness and possibly make it available through the CPPE website, which really is the go-to for pharmacists who can then promote it within their teams. So I'll continue to take this forward after this event. Next slide, please. I just wanted to draw your attention and to plug the pharmacy webinar, which took place on Tuesday evening and is available to watch back. It included some interesting presentations from London-based pharmacists on services that they have been providing, including a pharmacist-led clinic, the use of dashboards to make targeted intervention, and a community pharmacist contribution to addressing patient exposure to pollution in North East London. Next slide, please. And I just wanted to finish off by telling you about really interesting developments in the pharmacy workforce, which will no doubt play an important role in improving the future of asthma care. So from 2026, all graduating pharmacists will have an independent prescribing qualification. So currently only 29% of the pharmacist workforce are independent prescribers. Practice-based pharmacists, advanced practitioners and consultant pharmacists are all usually prescribers. And this qualification is increasingly being undertaken by community pharmacists. But as the new workforce qualifies, this is a unique opportunity to expand existing practice, to provide frontline healthcare services and ensure that the clinical skills and capabilities are utilised and form part of the wider shift in healthcare to improve access to quality asthma care for children and young people. Next slide, please. So that's me. Sorry if I've bombarded you or spoken a little bit too fast, but hopefully I've illustrated to you that pharmacists and pharmacy teams are uniquely placed on the high street, primary, secondary and tertiary care settings to help children and young people with asthma live their best lives. And if just pop the last slide, please. Just a little bit of thanks to people who have contributed to me pulling this together, because I come from a secondary tertiary care background, so need a little help with some of the primary care aspects. Thank you.